It's a real pleasure to welcome you to this demonstration on behalf of the World Federation of Haemophilia. In particular on behalf of the Laboratory Sciences Committee. My name's Steve Kitchen, I'm a laboratory scientist, I'm a member of the Laboratory Sciences Committee. Our current chair is Dr. Sukesh Nair in India. He's also had a major input into this demonstration. So it's our intention to make a demonstration related to APPT testing, because as you know, APPT is a pretty crucial part of our initial investigations in relation to patients with potential bleeding disorders. For the purposes of the demonstration, we'll be working in the water bath, and we'll be working with manual technique. And that's because we recognise that many of us have quite different automation, semi-automated, fully automated analyzers in our laboratories. And our intention was really to talk about the principles, the kind of pattern of results which are obtained in APPT, and really some of the ways to interpret these results, and to try and do something which you can take and make use of when you're working in your own centres. Actually, I think it's essential for all hemostasis laboratories to have available a water bath like this. It's particularly useful to control the thawing conditions for frozen samples. Many of us will perform tests on frozen patient samples from time to time. I imagine many of you will do the same. And I think it's important then to follow careful thawing conditions. We should thaw plasmas for 3 to 5 minutes in the water bath. They should not thaw at room temperature, otherwise we risk cryoprecipitation and loss of some of the important proteins. So I think we all need a water bath. It's also particularly useful if we make use of frozen control materials. You know that controls are a really important part of our testing, and we'll be discussing those in a moment. It's perfectly acceptable to use freeze-dried, lyophilized control materials. This is common practice in many laboratories, and that's fine, they work extremely well. But I think there are also advantages to frozen control materials, and subject to the local ethics conditions, actually we can make use of frozen controls also to take account of the costs and to make savings. In the UK, for example, we have the Human Tissue Act, which permits the use of residual plasma. When we've completed our diagnostic testing, any residual plasma we're allowed to make use of for quality control purposes. And that's particularly useful because it means we can harvest residual samples, plasmas from patients, and we can use this to construct control materials. And I think there are a number of advantages to this. An obvious one is cost, of course, but I think in addition to that, such a sample, because it's a patient material, it's closer in its properties to patient samples, and I'm sure that's an advantage, because it's difficult to keep control materials with the same properties when we have to go through freeze-drying lyophilization. So I think there are a number of advantages. When it comes to the water bath, it's important that we use calibrated thermometers. The temperature is crucial. All of the testing we're doing and the thawing is of course influenced by the temperature. We'll be running some manual APPT tests in a moment, and in this case the water baths that are used should be carefully controlled, and the temperature should be recorded. We use a system in my lab with where there's a bottle of fluid, and you can see the wire links to the device, and the device monitors the temperature. So we've got a record of that, and I think that's important so that we know that we're working within the limits. And of course we want to work at 37 degrees, as we are at the moment, but we have some tolerance, and we should be using a water bath where we're able to keep that controlled within plus or minus 1 degree at the most, and then I think we're in an appropriate area for testing. We'll be doing some tests with 2 different APPT reagents, and these 2 reagents are different. They have different phospholipid concentrations, and we'll talk more about that in a moment as we begin the testing. They also have different activators, and there is a growing interest and focus on the activators present in APPT reagents particularly as we're beginning to see increased use of extended half-life products, factor 8 and factor 9, in development and beginning to be used, and it's becoming clear that the activator in APPT reagent can have an important influence on the results which we obtain, particularly when we use that reagent in a factor 8 assay. So I think there is increasing interest, and we'll talk in the next 30-40 minutes or so about the way in which the activator can have an impact on the results that we obtain. The full protocol and some comments related to APPT are contained in the World Federation of Haemophilia Laboratory Manual. This is a resource produced by the Laboratory Sciences Committee, and I'm pleased to say it's available on the World Federation of Haemophilia website. I think you know the address, www.wfh.org. There's a publications section, and there are a number of, I think, useful publications available. It's possible to download the manual as a single document, but we recognise that people don't necessarily want all the sections, and so we've now set it up in such a way that it's possible to download an individual section or sections. We also recognise that English language is not the first language, of course. Of all people interested in WFH, it's an international organisation, as you know, and therefore I'm also very pleased that we have available on the website translated versions in Spanish. It's been very popular. Also in French, in Russian, in Arabic, and in Chinese. And we'll keep monitoring in the future whether there is a need for other versions. I'm aware that some local national member organisations have made translations into other languages, and I think that's a useful thing to do. Okay, so we'll press on now with some APPT testing. We'll be using two different reagents, and these have different phospholipids, different activators. We'll be running these tests in the water bath. So the first thing I need to do, once I've put the gloves on, first thing I need to do is to put out some APPT reagent into the water bath to be warming. And of course, when we move a reagent from a primary to a secondary vial, either in the water bath as we're now doing, or on an autoanalyzer, we have to pay attention to the fact that we may have altered the stability conditions. So we need to use the reagent during its period of stability in its secondary vial. And I think for an automated system, we should pay careful attention to the recommendations of the manufacturer. Just now we're working in a water bath. It's important to choose an appropriate secondary container. And for many plasmas and some reagents, we noticed that the reagents are less affected if they're moved into secondary containers comprising plastic, and sometimes there can be problems with some types of glass. So I'm going to use plastic tubes on this occasion. Some activators are particulate. Kaolin in particular is a visible particulate activator. This particular reagent contains a very small micronized silica particles, and some particulate activators, particularly kaolin, will settle and sediment during storage. That's not such a problem with silica, but nevertheless, if we're moving into a secondary vial, we have to be sure that we've fully resuspended any activator before we put out the secondary vial. If we were working in the water bath now for 2, 3, 4 hours, then there is the potential at 37 for evaporation, and that can change the evaporation of the reagent. That can change the performance and stability of the material. So we should cap the vials if the material will be in the water bath for any length of time. And this can be done with plastic lab film, for example. So we need to leave this in at 37, so the level of water is above the level of fluid in the tube, fully immersed so that it will come up to temperature. We know that plastic is not quite so efficient to heat transfer as glass, so it will take a few minutes for this to reach 37 degrees. So we'll leave that to be warming. The second reagent, as you know I'm sure, for an APPT is calcium chloride. There's no absolute agreement on which concentration should be used. However, the vast majority of reagent manufacturers, the vast majority of laboratories are using 25 millimolar calcium chloride. If you maintain a stock solution at molar concentration, that's a 1 in 40 dilution in distilled water. This is the most frequently used concentration. There are manufacturers who recommend alternatives. At least one uses 20 millimolar, for example. And I think you should follow the manufacturer's recommendation, the manufacturer of the APPT reagent. But again, the most frequent is 25 millimolar. So that's the concentration we'll be using just now. So again, I need to make sure that we have a solution of calcium chloride, also at operating temperature 37. So this will also go in the water bath now to be coming up to temperature. If this were an autoanalyzer, same issue. We'd want the reagents to be on board the analyzer for sufficient time in order that they would reach the operating temperature on the platform of the analyzer. So this also goes in the water bath. I think whenever we're performing APPT reagents, APPT tests, whenever we're performing APPT tests, it's really important to begin with a control. We have guidelines available to us, the WFH Laboratory Manual we've already mentioned, but also other national and international guidelines. And a common feature in all of those guidelines in relation to APPT is that we should test at least 2 levels of control. I think 2 levels is adequate. But there should be levels with different results. We need a normal control, and that tells us that the method is under control in an important area, that we're able to obtain good results in normal samples. But of course, some of the key samples that we'll be testing are patients with abnormalities. We're interested in particular, of course, in bleeding disorders. So we want to be confident that our method is also working well when we're dealing with prolonged APTTs. So I think the second level of control should be effectively an abnormal in a critical area. So we've got some degree of prolongation. It's acceptable to use lyophilized controls, but I think there are some advantages also to using frozen materials. The properties of the control material should be as close as possible to patient samples. And if we use frozen controls, we have less potential to introduce changes. It's ideal to begin with patient samples for the abnormal, and this is why I think it's useful if ethical rules in operation allow us to harvest residual plasma from patient samples. If we do this, then it's acceptable to make a series of small pools. Perhaps this is done on a series of different days, 20 mils today, 20 mils tomorrow, 20 mils over a series of days, and these can be deep frozen. They should be frozen at an appropriate temperature, and that really means at least minus 35, minus 50, minus 70. We should not be storing those materials deep frozen at minus 20. Particularly for APPT, we can begin to see changes during storage, and that can be a problem. So we need sufficiently low storage conditions. If we harvest on a series of days plasmas in this way, and we begin to build a large volume, but in separate 20, 30 mil aliquots, when we have sufficient material, these can all be thawed, pooled, and aliquoted. It's key, absolutely essential, that each of those aliquots of the control material is identical to all the others, as close as we're able to make it. So we should treat each of those aliquots in the same way. So we thaw and pool. We make a single pool of all the material. We aliquot in a series of vials, and all of that aliquoting is done in small volumes. 0.5 ml is acceptable, 1 ml is acceptable. In small volumes, and once all the aliquoting is completed, then those samples are transferred all together into the freezer for storage, so that they're aliquoted together, frozen together. This way there is a better chance that they are identical to each other in the conditions that they've been exposed to. So we'll be using a normal control. And this is prepared in this way. It's been thawed in the water bath. And when we thaw in the water bath, this should be for somewhere between 3 to 5 minutes. When we've completed that thawing, mix by inversion, just in case there has been any precipitation of, for instance, von Willebrand factor during the processing and storage. Shouldn't happen, but this allows for that possibility and resuspends any precipitate that may have occurred. So we have a normal control. The reagents will be up to temperature, so we're able to proceed. The testing itself. For manual testing, should be in glass test tubes. These are borosilicate, and the nature of the glass tube is not so important, but I think it can have some impact on the results that we obtain. For APTT, for manual testing, I think it's important to test in duplicate. The precision of manual testing is not as good as the precision of APTT testing on automated systems. It's more variable, so we expect to see a higher CV for manual testing. It's for an internal QC material, it's going to usually be in the order of 5 to 10%. So it's an acceptable level for patient management purposes, but is not at the level of 2 to 3% that might occur on an automated analyzer. Therefore, we need to test in duplicate.